So I feel like 2023 was the year that people only talked about two things in healthcare: GLP-1s or GPT 3.5 or 4, depending on how much money we're willing to shell out.
You're the only one who's talking about GLP-1s this much, and I can't tell if it's because you're on this weight loss journey that no one knows about, or
this is why we're doing a podcast. No one can see that. But I do feel like everyone was talking about large language models. How do we bring it to our orgs? Like, what does an AI first organization look like? It's all these like hand wavy buzzwords. But it was cool to talk to Matthew, who, at Summer Health, they're trying to like make this practically an AI first organization, and what some of the things they've been trying to do that have worked really well.
I feel like Matthew could grow like a Dumbledore-sized beard and talk about AI all day, and I would just like sit there and listen like his pupil. He's just like so wise.
Only you talk about people as Dumbledore of things, so...
That's true, the second time I've done that.
Exactly.
No, but for real, he was like spitting all this wisdom and just like simple reframes. Like he was like, look at GPT as your intern. And I was like, oh shit, like I would do that so differently now. So I think you just like reframed so much of the hand wavy stuff into actually useful ways to use AI.
Totally. I think there's a lot of really practical stuff people can take away from this episode, especially if they're trying to prototype a lot of new products, and hopefully take a listen, and some of this applies to things you're trying to do within your own org. So take a listen and let us know what you think, and we're excited to do more of these.
Yeah. Welcome, Matthew. Stoked to have you on here.
Are you happy to be here? Are you ready to have fun?
I'm ready. I'm ready to start my creator journey, my influencer journey. I'm joking. I just want to talk about the nitty gritty stuff. It should be fun with you guys.
Step 1, not do podcast interviews from a phone booth. Yes. Just kidding.
Step 2, get a microphone and headphones that work.
Just kidding. We're not going to roast you the whole time, I promise.
Matthew, maybe you can start us off by sharing a bit about what Summer Health is and what y'all do.
Yeah, so Summer Health is an asynchronous messaging platform, and we focusing on SMS as the primary channel. And we really focus on helping parents turn primary care into everyday care, especially with, the shortage of pediatricians. And so parents can easily reach a doctor within, on average, like 2.5 minutes. And on top of that, we've built not only the access to primary care, but also specialists. So everything from nutrition, lactation, sleep, and coming soon behavioral. So that's in a nutshell what Summer Health is.
Can you tell me a little bit about like how you hit that SLA of like under X number of minutes for SMS? Like, is that like pulled out of your ass kind of thing, or is there like science behind it?
No, well, I think that I would say that there's two parts to that question. Like one, how did we come up with an SLA that we thought was compelling? And then two, what our actual SLA is. And basically, when we started Summer Health and we did user research, we heard from people that the most similar kind of analogy is calling a nurse hotline, where one, they would have to wait to get in touch with a nurse, and then two, they would have to wait to hear back from the nurse on, from an actual doctor. And typically that process took about 2 to 3 hours. And we thought to ourselves, well, if you wanted to make this 10 times better, what would that be? And we landed at about 15-minute SLA. The second thing is, we track this religiously, and it's one of our goals that every single month that we have a 95% SLA. Currently it's around 96.7%, but that's, more or less kind of where we landed. And right now, as of November, it was 2.87 minutes was the average wait time for someone to get in touch with a doctor. Obviously, you can go into specific of how we make that happen, but that's kind of the...
That's better response time than my parents and my friends.
Which is very impressive.
My mom answers that fast, but it's usually like one-word answers that are like totally off base and not related to anything that I said before.
SLA achieved if you just say, okay.
Yeah. Can you give me a sense of your scale? So was 2.87 or whatever that number is, it's now. What was it like on day 0? And then like what were some of the evolution of that SLA? And also on top of that, if you could share a bit more on just like how many texts we're talking about here and the general volume.
Yeah, so we've been around for about 1.5 years, and we've done over 10,000 visits. So pretty sizable sample size of our ability to deliver on the SLA. When we first started out, our SLA was about 85% in terms of 15 minutes. And actually, the funny story is that we went into a board meeting with our investors, and they're like, if you promise a 50-minute SLA, it better be over 90%. And then we spent the next 3 months just optimizing our operations to really make sure that we could hit that. And kudos to, all to say that the investor, it was Alfred Lin at Sequoia. Kudos to him. Like once we really focused on that metric, we really saw retention improve and engagement, and people started to use this in a different way. It's similar to how when people first started using Uber, it was really just a taxi service or maybe to the airport. But because it was so easy to use, people started to use it for grocery runs and like nights out in the town. So we kind of saw a very similar behavior as we started to really improve the speed at which we were able to deliver care.
Can you talk a little bit about like what the hardest things were to go from the 85% SLA to where you are now? Like what things had to change? Is it like you're triaging requests inbound? Is it like dealing with, figuring out like where do you introduce tech? Is it staffing? Like what are the main levers you use to basically reduce the SLA time?
I would say it's two things. One was the staffing, and then two was just the systems we built around routing. And then the last thing I'll say, maybe to start off, is we approached it from a very naive perspective. And maybe it's because no one on the team, aside from our CEO, Alan, had worked in healthcare before, but we didn't really think like, oh, let's like supplement this with nurse practitioners or PAs. We really wanted to keep to the promise of getting people to doctors immediately, regardless of how big or small the question was. So the way we approached it was, one, from a staffing perspective, how do we make sure that there is a provider on at any given time? And what we ended up doing was we started to really focus on providers that had multiple licenses, and really started to recruit really heavily on that. And I think at this point, we've probably cornered the market for pediatricians that have 50 state licenses. I think we probably have 80% of the pediatricians that have that type of coverage, and therefore allows us to basically have someone on at any given time. So that's more of a staffing / scheduling solution there. The second thing that we did was, again, I'm not sure how other people do it, but we had built our entire routing system from the ground up. And so it started off with a very simple round robin. But what we would do is every time we would try to route it to a particular doctor, if they didn't respond within 5 minutes, we would route it to the next doctor that was available. If a doctor that wasn't available at the 10-minute mark, then we would actually page an on-call operations. So at the beginning, that was me and Tim, my head of ops. And then from there, we would like manually start calling our doctors, like literally just like pulling up the phone, calling them, be like, hey, can you get online and take this particular patient? And that's basically the two things that really honed in on us being able to route it. I think the other thing too is that we didn't, we weren't relying on some type of app to like set a push notif. We would actually start to set up very similar to how engineers have on calls. We basically have pager duty for doctors, where if they didn't respond after a given time, we would first, send them an SMS. If they didn't respond by SMS, we then, basically call them using pager duty. Obviously our own version of pager duty internally. So that's kind of how we approach it from a very traditional engineering software type of approach when it comes to on-call.
Are you getting calls in like the middle of the night? Like, are you getting these escalations and you're like, oh shit, it's 2 a.m. I gotta like call a doc now?
Definitely in the beginning, first couple of months, wasn't great for my relationship. But now I would say it's probably closer to like maybe once a month, and we now do it on a rotation between 3 different people in ops. So
wait, isn't your partner a doctor?
My partner is a doctor. That being said, she is a dermatologist, so she doesn't quite get the on-call situation like I do. It's ironic.
You're in bed and you're just like, can you take this one? I can't.
The true ops hack no one wants to talk about. Marry a doctor.
Yeah. The other thing I'll say is definitely, if you're planning to do this on-call, have an Apple Watch or something that's going to buzz you instead of using an actual phone alarm. It would definitely help with the conflicts with your partner.
So do you send all your doctors an Apple Watch now?
No, but mainly for op. Maybe that's something we should think about, but no, it's mainly for the people on the ops team.
So I'm going to summarize that back because I think there was so much value in there before we move on. So the first thing I heard you say was staffing. So you hired folks that could have built-in redundancies because they could basically take a patient from anywhere, which means you wouldn't have to delegate that task out to folks that could only service in that particular geography, which is like a super smart way to think about building in redundancy. And then the second thing was a lot of the routing systems. So you were incredibly tight around SLA and escalations in really, really short intervals to make sure somebody was aware of it and that an action was taken. Is that sort of like the two big pieces of it?
Yeah, I think those are the two big pieces of it. And obviously there's data analysis that goes into when are you experiencing the most SLAs and making sure that you have redundancies there. But, that's in a nutshell kind of how we approached it.
What are some of those like edge cases or times of high volume that break your systems?
Yeah, so what we found was that the times that broke our system in the early days was between 7 p.m. to about 12 a.m. Makes a lot of sense because parents are just getting off work and, the pediatric office is often closed, or even the urgent care, frankly. And then also in the morning. So when they wake up and their kid's suddenly sick and they can't bring the kid to school, they're now reaching out to us. And so there was also, I think the time of like 8 a.m. to 11 a.m. was also a really busy time for us as well. So kind of like that sweet spot.
I'm curious, just like follow up on one of the things you said before about how like behavior change happened as you shortened the SLAs over time. Like, can you give us some examples of like, here's like an emergent behavior that like came out that we didn't really expect, or as we shortened things down, like we saw these new types of interactions that we had to, basically deal with.
Yeah. So just to share, we started off with a very simple hypothesis, which is if you were the fastest way to get care, that's how we would win in the market. And while that was true for urgent care, as you mentioned, we started to see other types of behavior. So instead of people just coming in and sharing, hey, my kid had a fever, X, Y, and Z symptoms, should I bring in the urgent care? We started to get parents, especially in the middle of the day, just having some type of question around, hey, I'm trying to get my kid to sleep longer. How should I think about it? Or, hey, I'm planning to transition them from, breastfeeding to formula. How should I think about that? How should I think about that? What are some of the side effects? Hey, kid was exposed to XYZ. Is that something I should be concerned about? Or, hey, I think he might have this allergy. How do I go about testing that? And so I think that was kind of where we started to see the need to bring in specialists to help answer some of those questions and triage. We actually had a kind of an internal e-consult model, but we wanted to, give that access to parents and really empower them. I think the other second emergent behavior that was really interesting was, and I think this is how we want some of our lifelong fans of Summer Health, which is sometimes when you have to go into the urgent care or emergency room, you're really scared as a parent. And the doctor's asking you a lot of questions. There's a lot of anxiety you have of like, hey, am I explaining the situation correctly? So because of our asynchronous SMS model, parents actually brought us into the emergency room. We would have 4 to 5 hour sessions where they'd be like, hey, the doctor said X, Y, Z. What should I ask? How should I explain what's going on? And then they would then explain to our Summer Health pediatricians, hey, the doctor said this. Should I be concerned or not? So I think it just enabled a very different interaction model that just doesn't exist in the market, really.
Wow.
Yeah, that's super interesting. I'm sure a lot of people probably listening to this have been in a situation where they're like sitting in the ER waiting for the next appointment, or, they're kind of like not listening super closely because they're like, dealing with something relatively traumatic, and having someone who's like almost a champion in the room with you. I feel like it's like that. It's like the having a doctor friend or like having a doctor parent, right? That's kind of like the dream a little bit.
Exactly.
I think the overarching takeaway for me is like the quote, the best ability is availability. And you've just nailed that, of just being constantly available. Are there any kind of scheduling? My ops brain is going off a little bit because you're talking about 4-hour sessions, not just like what traditional async can feel like, which is like one-off things. So like, how do you manage more longer interactions? And then from there, we can totally jump into AI and pick your brain on that.
Yeah, I think that, the reason why the interesting thing about SMS and maybe just broadly asynchronous care, at least what we have found so far, and there's probably other factors that we can get into, is that because it's not like a video call or an in-person call, doctors don't have to, doctors, let me put it this way, they don't have to be on for the entire time. They can manage multiple conversations at the same time. And so they don't really feel this pressure to be like, hey, I need to fit the session with a 15-minute because I had to hit a certain quota to make X amount of dollars. And I think the second thing is because messaging is so much easier than having to get ready for a video call and to constantly be, I know, when like, I guess when you're on a video call, you often have to show a certain level of emotion and expression. And that's actually like really, that takes a lot of energy and effort. But with SMS, it's pretty effortless. In fact, some of our doctors probably not the best model, but they, not the best work-life balance. They sometimes provide care while they're having dinner with their family, but like it's that easy so that when an interaction lasts 4 hours, we actually haven't heard from our doctors that they have a problem with that. And we don't pay them any more for that session than they do for something that maybe lasts, on average, typically 15 to 20 minutes. So I think asynchronous is both beneficial, not just for the caregiver, but also the doctor.
I guess maybe switching gears now, and we can talk a little bit about AI since that's what the people want to hear. But so you guys started, you said a year and a half ago, right? So I'm guessing large language model craze and hype had already taken hold at that point. First of all, did Summer Health kind of come out of the idea that hey, AI might play a core role here, or is it you guys started, then this came out, and you're like, oh, we should totally be doing this for a lot more stuff internally?
Yeah, I would say that we were excited about the developments in the GPT space. I think around that time when we started, GPT-3 was maybe not even GPT-3, GPT 2.5 was kind of in the wild. And, we had a hypothesis that, probably in the next 5 years this would happen, or maybe 10 years this would happen, and that you would need to have a lot of interactions and medical data to basically be able to train your models. And so in some ways, we always were kind of building towards that vision, but we just didn't know how fast that vision would come to actuality. And so when we saw the performance of, GPT-4 on a bunch of the medical license exams, that's when we got really excited, because that vision that we thought was 5 years out that had all these prerequisites suddenly came to the fold. And obviously this is where we can start talking more about, but it was always part of the plan, but we just didn't think the plan would happen so soon. And we thought we needed a lot of other things to be there for that to happen.
So you see GPT-4, what's the first thing that you're oh, we definitely need to use that here?
Basically, just to be really clear, what got us really excited about was obviously, the explosion of ChatGPT. So I don't want to say that I'm some type of oracle that knew this ahead of time. I didn't really understand the full application of it. But once ChatGPT came about and you start to play around with it, you're like, wow, this is really amazing. What could we do with the API? And for about a month, there was nothing that we really could do. All I started to do was start to ask on behalf of my CEO permission to use her conversations on Summer Health to basically see what was possible. So I was trying to do things like, could I generate a medical note? Can I probably pretend to try to diagnose, some of the symptoms? What's the difference between, ChatGPT answering a parent's concern question versus a real doctor? I'm really just trying to understand the use cases. Didn't know what would happen, but just was really interested in that. Probably about a month and a half later, because I think the craze of ChatGPT probably started towards the tail end of November. And then probably around late January, I heard some rumblings that OpenAI might offer a BAA for HIPAA. And so immediately I had a few friends that worked there as early engineers reach out to them like, hey, can you put me in touch with whoever is reviewing these applications? And that's when I got put in touch with their head of go-to-market. And a month later, probably towards the end of February, early March, we had signed a BAA with OpenAI. And so that's kind of how that transpired.
Wow. I'm like sitting low on that wait list to get on GPT-4 right now.
Well, I feel like independent, people do are probably not high on their priority list. I don't think they're ever going to give it to me either.
You don't matter.
Yes. I'll try to put it in a good way for you, Danielle.
Yeah, definitely. Look it up. Come on. I'm sure everyone that's listening to this is like, oh my God, how do I get a BAA with OpenAI? Like, that sounds like holy grail. What did that process look like aside from texting those friends and engineers? And have you seen it done in a not backdoor way since then?
Yeah. So the process looked like: one, make an intro; two, jump on the call. They really cared a lot about obviously user risk and safety. They didn't want people to be creating these AI doctors that would basically replace the need to actually talk to a medical professional. So they're really vetting my use case, making sure it's a low risk use case where we're planning to use it first. And that's partly why we first jumped into medical note summarization, because that's a fairly low risk. We still keep a human in the loop. And so they really got into the details of how we were planning to implement this and how do we plan to mitigate risk. And that's, I think, what helped us push us over the finish line, truthfully. So that's kind of where it started. We're actually going to be launching a case study on summer health with OpenAI next week. So, stay tuned for that.
Cool.
Oh, cool.
So do they put guardrails? So they put guardrails around the use cases that you're allowed to use it for? And is it basically like, hey, if you do anything outside this, like, no dice, we're going to cut you off?
Yeah. So basically after the call with the head of the GTM there, he sent me a document of the types of use cases they would allow and just make sure that we're actually doing this. And then I had to write another email that reinforced, what we're actually planning to use it for. And if that materially changed, I would reach out to them. And then it basically went into an application process. And I think the CTO at that time was reviewing every single application to make sure that it was a safe use case.
Wow, that's crazy.
Since then, have you figured out, have there been other BAAs in place that you've seen from other digital health companies, or has that slowed down and demand's too high and everybody's sitting on that wait list like me?
Yeah, so after March, let's see, maybe 2 months later, so that's now April or so, I was at a dinner and someone's like, oh, how did, what are you doing? And I talked a little bit about the BAA with OpenAI. I think around that time you could still get it, but it would then cost you money. So we didn't pay anything for our BAA with OpenAI because we were just so early. I think at that time they were starting to charge closer to 10,000 or so. I don't know the exact figure, but somewhere in that range. Now it sounds like, again, I haven't really been keeping in touch. I probably should. It sounds like it's really difficult to get, but that's all I know as of right now.
It's kind of an interesting question too that's open, which is like, when depending on how much they charge for this, right? There's still like is this cheaper than a human being to do the same task kind of question, like especially depending on if you can outsource it overseas and all this kind of stuff, right? Like when it's free, you can just mess around, like do whatever, like anything's possible, right? But I do think there's has to be a cost inflection point, and also like maybe a PHI sort of like PHI question around like how the data flows, that for it to actually be usable in a lot of these contexts that people have been dreaming of, right? Because it's like, right. Listen, if it's $7 or $10, whatever per interaction with this thing, it's like that's not feasible, right?
Yeah, I mean, obviously, I think that I would think about it two ways. There's like the fixed costs of signing the BAA, and then there's the actual API usage cost that's charged on a per token basis. And I'm totally gonna butcher this, and so someone should just look it up and verify. But it's like 0.00001 cent. And so the amount of API calls that we've made over the course of 4 to 5 months of doing tens of thousands of visits has been like $500, right? And if you were to use a service, one of the vendors out there that could do this auto generation, you're paying close to 100K in some cases, and so. Yeah, there's definitely that cost inflection point for sure. But, if you do have the technical capabilities and able to sign BA, I think it's significantly cheaper, personally.
Did you consider any of the other large language models when you were looking for a partner on this? And also like now, like sort of maybe post OpenAI debacle, like do you think about like diversifying like the partner base that you work with for this kind of stuff? Or is it just better to go all in on one?
Yeah, so I would say in the beginning, we didn't consider any large language models just in terms of a base foundational model. I think at that time, OpenAI, and I think, to be honest, caught everyone else off guard. So they were kind of the only game in town.
I mean, it caught them off guard.
Caught them off guard too, exactly. I would say now, looking forward, we are in discussions with Google as well. We played around with Palm. It does seem to hallucinate a little bit more than GPT-4. That being said, they do have a medical based language model being MedPalm, and so we're currently on the wait list. I think hopefully by the end of the year we're supposed to be off that wait list to start using it. And we're really curious to see, how that performs relative to OpenAI on things like medical summarizations. The interesting thing, though, talking to the team at Google, is that there is a difference in terms of how different large language models based on the different use cases. So, for example, what they've seen internally is that Palm is much better at summarizing the parent or patient side of the conversation, and MedPalm is much better at summarizing and synthesizing insights from the doctor. So we definitely see a world where we'll start to use different models for different types of use cases, and also speed. For example, if there is a huge volume of traffic on certain large language models, the speed in which we need the return might be too long. So we might want to look into something like Llama, where we can have a little bit more control of the compute. So we are definitely, personally, internally, we're looking at more of a platform in terms of how we can leverage multiple different large language models and really kind of fine tune their use case.
One thing I've heard you talk about is the sophistication and the nuance of prompt engineering, and how you worked a lot on making sure you were asking the right questions, which probably saves you a lot of money because the number of API calls are, the API calls are just better because you know exactly what you want out of it. Can you give us the story on the whole kind of saga and build up towards designing the right prompt and the original kind of thinking around using AI for clinical notes?
All my homies are chaining prompts nowadays. That's like the new pastime.
Yeah. I would say that there's a couple of things that was really helpful for us to get started. So one was that, to start, again, obviously ask for permission to use certain types of information, but if you're comfortable sharing your own medical information with ChatGPT, just start there. Just figure out, hey, if I were to post X amount of data into ChatGPT and give it a particular prompt, what would it get as the output? That generally is enough to generate some type of excitement within the company. Based on that, I suggested to our CEO, hey, let's have a hackathon. Let's really try to see what we could possibly do in just 2 days. And so from there, one of our engineers, I didn't think of this, but he basically set up what we call a Python notebook. I think it's pretty standard in the data science community, where it really made it really easy for us to basically create a template that our team could use to start kind of playing around with, hey, if you were to input an X conversation and had this prompt, what would the output be? So we had that set up before the hackathon, and during the hackathon, our head of clinical worked really closely with our engineer, and basically started with the most basic, being hey, here's a conversation, please summarize in X presentation. And then the next iteration was okay, that was 3 out of 5 in terms of evaluation. Let's get a little bit more specific. For the diagnosis, please try to use more, grade 5 language terminology, remove pronouns, very, very specific. I think one analogy or metaphor that you can use for how you interface with GPT is to think of it not as an expert, but as an intern, right? Your intern is you can ask an intern to help save you time, but you really need to probe them both on the specifics and also how they came to the particular conclusion. And as you kind of iterate through that type of framework, you can get to a point where you can basically write a very detailed instruction set for an intern to basically produce a very reproducible output. And so for us, it took about probably 20 iterations over the span of 4 to 5 hours to basically come out with a prompt that our head of medical felt, basically when we tested it on internal use cases, was 87% of the time accurate. And that's actually, again, at that point, that was a small sample size of 20 conversations. Now, when we actually look at the real data, which is how often do providers edit the kind of medical note from the prompt, it more or less is 84 to 85%. So, it's interesting how heuristics kind of play out at a larger scale as well.
You must have had much more competent interns than I've managed in the past. Just kidding. All my interns, please don't mail me for this.
You guys still have jobs, is what Nikhil is saying.
That's true. That's true.
What's your general take on AI in your company now?
I would say that there's probably a couple different angles or layers to look at this. One is just how do you embed AI into every part of your company in terms of its operating cadence and system. And so, step one is there are so many tools that many startups use now, whether that be Notion or Loom or Zoom. Just turn on the AI features. I know it costs more, but it's going to save a ton of time. There was a time where I would do a user research interview, recorded it on Zoom, watch it again, get the key insights, share it with the team. That literally took me, I don't know, maybe like 30 to 40 minutes. Now all I do is I copy the transcript, put it into Notion, ask Notion to summarize it, and like within 10 minutes, I have all the insights that I need to share with the team. The second thing that was really interesting is like, how do you start enabling better cross collaboration across different functional areas and actually allow everyone in your company to up-level themselves? And so the really cool thing that we saw internally was that now our head of clinical or even our head of ops has GPT to help them analyze and understand our data better by using it to, generate queries using SQL. But when the trick is to actually pair them with a data scientist so that if they ever do get stuck, there is a real human being that can that can unblock them. But most of the time now, 80% of the time, they're able to just figure out on their own exactly what they need versus in the past, we just had this massive queue for a data scientist. Our data scientist, interestingly, started to work much more closely with our engineers, and she basically became like a data engineer / like backend engineer that created a lot of application for us to do things like the auto generation of care plans that are hyper personalized based on the user. So that was really fascinating. So the point being that like you can really allow almost everyone in your company to operate at the top of their license, kind of like in the medical term, or MP or I guess PAs are acting, in some ways as doctors internally as your company because of AI. And then the third thing, obviously, is just how we approach every single product problem. I would say right now it's more of a distributed expectation that everyone is thinking about how do we leverage AI in all of our workflows. But that being said, as we start to be more sophisticated in tying multiple models together, I could definitely see a world where we hire a specialist to come in. And right now, we basically have an expectation that everyone in the company is constantly thinking about how do we integrate AI. So there is no specialist. Everyone, one of the big hot takes is that, in the past, whether you invest in AI was a strategic choice. Right now, it's just an imperative. That being said, as we get more sophisticated, as I kind of mentioned, where there's now not only is there multiple language models, but there's multiple modalities in which large language models can play in. I definitely say within the next 6 to 12 months, we'll probably hire someone that's more focused on this particular space to constantly help us be at the bleeding edge.
Well, that's interesting. One thing I wanted to ask is like, so for example, in that Notion use case, right, of like, hey, we're going to record a user interview, we're going to bring it to Notion, ask Notion to summarize. Do you like check to basically see like, okay, how good was the summarization versus like if I did it myself, I would have maybe done X, Y, and Z? Because one thing that I think about is like, if everyone is using a lot of these tools, like AI kind of spits like the most like, I don't know how to say this, but like mid-wit answers, right? It's like the exact like average quality answers in most cases versus like, I feel like a lot of really, important startup insights come from these like random fringe emergent behaviors or like weird things that maybe like you yourself think are important, but maybe the AI does not, for example, right? So I'm curious, like, do you battle test the AI features? Have you noticed, for example, also some companies have done a better job with their AI, kind of like turn on tools?
Yeah. So there's a couple of questions there. There's one, how effective is it? And, two, can you pull out the nuance? And then three, now, are there certain tools that are better than others? So the first question is, yeah, in the beginning, I definitely, I would write notes during the user research session, and then I would compare what was basically been able to pull out of, let's say, using Notion's AI. I would say like it got 80% of the way there. And I think that's true of all of these AI kind of task automation. I think it's a fool's errand to try to get it to a point where it truly replaces the need for a real user researcher. I think if anything, it's an accelerant or an augmentation of your ability to focus on the things that matter the most, because there's some basic things that are going to be captured in every single user research survey, like the background of a particular person, what the care setup is at home, where do they live, what the profession is. All those psychographic things can just be pulled in through the summary tool, versus you can really now focus on more of the nuances. And so when you're reading the summary that the AI came up, you can just add to it where you really want to focus your time versus wasting your time, basically, sharing kind of the basic information that, is typical. The second thing is around, battle testing. I think that I wouldn't say battle tested, but what I've done iteratively is, and I mean, this is kind of the common theme, is you constantly iterate on the prompt, right? So if you notice it missed something, just iterate on the prompt. And in Notion, you can save the template. And so that's something that you can do. Actually, one thing I've been playing around with now is ChatGPT launched the ability to create your own ChatGPT. And so I've been playing around with that, where I'm trying to create my own prompts there and sharing it with my team, so that's easier for them to do things like user research or data analysis and whatnot. So that's something that I'm kind of playing around with. And then the third thing is their tools. I would say I'm going to say Notion's pretty good. I think it's really flexible. They have I think people have probably seen this. They have their new Q&A build tool. Luma's been fantastic. It just saves so much time, especially now. In the past, I would do a launch post. Right now, I just record a loop about a launch, and it basically summarizes it in a way that people can just consume it, which is great. So I think those two. And then if you're a little bit more advanced and you want to play around with it into more of your daily tools, there's a tool called Raycast that is a cool command launcher. And you can basically, assuming your company has access to OpenAI's GPT, you can basically get one of their API keys, put it in there, and use it in any app that you're using. So whether that be Google Sheets, I don't know, your email, whatever, it can get the context to basically help you automate a lot of things, or at least give you initial starting point for most things.
On your point, Nikhil, around this idea of catching the nuance, I think a lot of the challenges that we have in care delivery is just getting access to objective data in a way that's like right when you need it. So so many use cases that I have and I can't access because I'm on the wait list. So maybe me and you can sign an NDA and then I can use one of your logics.
Yeah.
Do you sign BAAs with individuals? Yeah, but anyways, just the sheer information retrieval problem that we have on high amounts of data that otherwise are just over Zendesk, Notion, XYZ, and just being able to aggregate it and ask simple questions, I think is so much value in and of itself, which I imagine that 3 minutes buys you quite a lot of time to do good information retrieval and good summarization of problems and even engineering problems, which you don't have that luxury when you're on a phone call. And it's crazy to me to think about it like that, because SMS now just unlocked time for you to do better back office functions. And in my head, that is worth its weight in gold. Did you know that it would be so valuable?
There's also, just to riff on that, there's also this open question now of how many tools you actually need to create libraries and databases on the back end to like keep things really meticulous and organized. Like, I know for companies I've worked with or worked at, like you use like combination of like Airtable and Notion, and you try to like your best to get everyone to follow these like really neat processes to keep things like detailed and organized so retrieval's easy. But if if large language models makes it super easy to just search across this stuff, it's almost like, hey, just dump it into one place. We'll figure it out later, right? So
yeah, 100%. And I think, Danielle, one of the questions you had put into you asked me previously was like, is there an idea that someone should run with if they wanted to start a company? And when someone should just rethink this whole like tracking health metrics space. It's like, I don't know if for the parents out there, there's like the I think it's Baby Center, there's like Huckleberry, there's all these different apps that allow you to track all these very specific metrics, but everyone does it for like maybe the first 2 weeks, and it's become so tedious that you just don't do it. There should be a way for you to just use your voice to basically say like unstructured information and turn it into structured information. I think that's the other way to kind of think about your question, Nikhil, which is like the inverse, which is even the input should be unstructured, and then the AI basically structures it in a way that makes it useful for you in the future. There's a really cool consumer app called AudioPen where I'll listen, because I love listening to audiobooks, and I always forget to like write my thoughts. And so after a chapter, I'll just like talk for a minute, and it's probably like 90% gibberish, but it takes the 10% that's not gibberish and like structures in a way that makes sense for me to reference later. So I think someone should do that for healthcare. And that would be, probably, really impactful.
I can just imagine you on like public transit, just like talking for a minute into your phone while everyone's staring at you, being like, "What's this dude doing?"
Everyone's focused on longevity, and Matthew's like, "I'm just going to AI the shit out of my life right now."
Yeah,
exactly. That's super interesting. I'm curious, so obviously we've talked a lot about text, right, as like one of the big modalities, and you've built a ton of asynchronous stuff. OpenAI has been coming out with all these new more multimodal stuff, right? Images and video soon, and audio, and all these other things. Have you considered other use cases that you might bring some of these more multimodal models into, or are you really just like hyper focused on text and trying to build those workflows there?
Yeah, I would say two things. One, continue to push on text. I think that one thing that was really interesting, and I think this is a phenomenon for everyone that has been leveraging the outputs of text GPT generation, obviously with some editing and accuracy checking, is that patients actually like the medical notes written by GPT more than they like the medical notes written by doctors. I don't know if anyone's ever gotten an actual useful note from a doctor, but it's usually like one or two sentences, whereas GPT actually really dives into the conversation and pulls out more like 5 or 6 sentences that really help the patient remember exactly what how the conversation went, and vice versa. The reason why I pull that out is that, one thing that's been challenging for us in text is that, words only make up 10% of communication. There's, the tonality and body language is obviously missing in SMS. So we're really trying to push the envelope of how do we actually help doctors communicate empathy and understanding for a parent. And I think that's something that, we haven't quite cracked yet, but that's something that we're actively thinking about. In terms of the other modalities, we're really excited about that. On a similar line, I don't know if anyone's tried the new, ChatGPT kind of voice interaction, but it sounds incredibly natural. There's an API that they expose that allows you to do that. It's called Whisper. We're starting to play around with it. Is there a way that we can help doctors communicate empathy by creating a synthesized voice for them? These are some really interesting things that I think, it's just hard to communicate via text unless you're using the right emojis. And, that's always a challenge because emojis can have many different meanings, as we know. So
I just respond with the upside down smiley face one each time because no one knows what it means, which is great.
Right.
You just never respond, is your
This SLA is terrible.
I have no SLAs.
Shittiest SLA of all
exactly.
Yeah. And then the other things, obviously, like image is going to be big, and same with video as well. And so we're really excited about how we can help doctors get a preliminary analysis of images, and also to give them higher confidence so that if there is a situation where we can act on that information, we can, versus sending them in person. And so not only are we talking to OpenAI about how we might leverage that, but we're also talking to Google because they also have a multimodal medical-based LLM that we're really excited to potentially use.
You alluded a few times to the word empathy and providers and the intersection of those two. And I understand that you're using a little bit of AI now to do some sort of scoring. Can you touch on that a little bit and what you're working on?
Yeah. So this is, one of the things where, it's been helpful because every quarter it used to be that our head of clinical and another provider would basically, do a sample size of 20 to 30 conversations to across all of our providers to get a better understanding of how the care is being delivered. And so one thing that we thought during the hackathon was, is there a way that we can actually use AI to help us score and understand how empathetic conversation was? And similar to what we did before, we basically, used the LLM to generate a score. We had a doctor evaluate it. And I would say the false positive is much higher in this case. So it wasn't the highest accuracy. It was closer to 70, 72% of the time it was accurate. But it allows us to get a better pulse to find any outliers for certain providers where, their empathy score was just really, really low. That being said, one thing that, because a lot of these things are more probabilistic, not deterministic, you really have to not just get a score, but get the LLM to explain why they scored at a particular level. And that gave us a better nuance because, for example, if a doctor's following up and the patient responds, "Thank you," they're going to give it a really low empathy score because, the length of the conversation was really short. There wasn't a lot of "Hey, I understand how you're feeling." And so, having that score was helpful, but getting into the nuance was more important to actually make it useful.
How do you find the right problems to solve with AI, and or have you developed some sort of framework about the right business cases to apply AI to?
Yeah, I think that, there's basically two axes that we look at. One is, how impactful is this particular problem if you were able to solve it in a much more personalized and higher quality way, and then like what level of AI autonomy is there. And anything that is kind of in the upper right corner where it's high impact and high AI autonomy, we try to really quickly validate it through some really quick prototyping. And then we basically focus on, making that and then much more scalable, or like systematize it. The second thing I'll say is that, one thing that we're just starting to think about is how do we internally create a really flexible way for a clinical team to leverage LLMs to help, I don't know what the right term is, but like help automate a lot of the flows leveraging LLMs, because there's a lot of, you can think of it as almost like Zapier, right? There's a lot of clinical information in the FHIR like standard. And so, when the patient closes a visit based on the patient's like medical history, blah, 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 here's a prompt, generate this particular task for a provider to do XYZ later. And so we can start to help the clinical team have more control in helping guide certain types of patterns for doctors to have, more proactive and quality care, if that makes sense. There's going to be more, there's more to come with that. And maybe, a couple months from now, I can share a little bit more about how we're building that platform internally.
Awesome. Well, we're sort of coming up towards the end of time. So one last question to like close things out. For a lot of companies that are probably maybe thinking about, hey, I want to bring AI into my org, or I want to become an AI first company, like, do you have any suggestions on, one, maybe like first small ways they can do that? And then also two, like, what are the big things to think about to make that transition that might help? And also, like, when should a company think about even doing that? Like, is everyone just like an AI first company now?
Well, I think everyone should be. To answer that question directly, and where to start, I think it's always about finding either yourself or someone in the company that has shown a lot of passion for it. And that might be because they're already commenting your Slack about all the different use cases. Task that person with trying to find some early quick wins by leveraging things that don't have to be HIPAA compliant initially, but just using ChatGPT to prove out some of the use cases that could be powerful. And then from there, it might be difficult to get a BEA, but there are ways in which you can strip out PHI information in a way that might be helpful. Or you look at some of the open source models like Llama, and you can host it on your own servers, and that way you don't actually have to worry anything about HIPAA. So, that would be the kind of third step. And the fourth step is assuming that you've generated some excitement. I know I've said this a few times, but like actually hosting a hackathon and bringing some of this to life with real clinical data, I think would go a long way. And the beauty of this is assuming that you have some type of interface to display the output. It took us like 2 days after the hackathon to implement it into our clinical workflow. I don't think it's like, some of the other prototypes in the past where, it would take you maybe months to get it onto the roadmap. Some of these things, once you get into a point that makes sense, as long as there is a human in the loop and somewhere where you can display the output, it probably gets 80% of the way there.
80% is like your general benchmark for how successful AI is, it seems like.
Pareto
exactly.
principle.
Pareto principle, where you only need to get 80% of the way there. I think it's a fool's errand to ever try to get to 100%.
My last question on that is maybe just how you solve for that other 20%. Do you always have a review step before something goes live? And especially if it's going to face a patient? And what are some of just those guardrails you have in place around the 20% failure mode?
Yeah, I mean, right now, there's always a human in the loop, and, there's no plans to ever kind of remove that step right now. So I think if we were to ever remove that step, we would just have to be much more diligent in trying to understand what's the right metric. It's really difficult to know what that right metric is. So for now, human in the loop, always. We do try to track, we track how often the doctors actually edit the medical note, how fast they hit sign. And so if you see some anomalies where literally the doctor's just hitting sign every single time without ever editing, we talk to them and be like, hey, it's really important that you review this type of information ahead of, or make sure that the AI is actually generating the right output. So that's mainly how we monitor it internally right now.
So I know I said last question, but I have one more follow up to that, which is, do the docs that you work with, like, are they generally excited about using AI
I was gonna
tools
say
for this
that
stuff? Like, I feel like, you know, when you're as internet brained as I am and you spend too much time online, people, all the docs, you know, it's very polarizing. Like, all the docs are like, AI bad, right? I assume, I mean, on the one hand, I'm sure there's like a self-selecting group of docs that like choose to work with you all if they, you know, if they weren't excited about AI, they probably are not like gravitating towards you. But I'm just curious, like, are the docs excited about it? Is there like some archetype of doctor that you've seen who's like particularly really leaning into this stuff?
I would say that our doctors love it. They think it's magic. So I think, especially when it comes to clinical, kind of administrative work, it used to take doctors probably 5 to 10 minutes to write the medical note. They usually batch it up, and then it would take collectively maybe hours. Now it takes like a minute to 2 minutes. And then in terms of like the type of doctor, honestly, we have doctors across the board. So we have ones that are purely focused on telemedicine. That we have ones that have practices that just want to be able to provide care without all the administrative burden. And I think across the board, all of them are excited about the ways in which AIs are just making their life easier so they can just focus on doing the thing that they care about most, which is just delivering care. So I think across the board, at least for the doctors on the Summer Health platform, they love it.
That's awesome. Great. Well, I think those are pretty much all the questions that we have. I want to just thank you for coming to chat. I think people are going to like learn a lot about places that they can hopefully implement a lot of these new AI tools in their own company. So thanks for coming to chat with us.
Oh, no problem. Hopefully it's helpful. And then, people can always reach me at matthew@summerhealth.com if they ever want to. That's my email. Hopefully I don't get a flood. If not, you'll be getting some chatbot responses.
Yeah, exactly.
I have gotten a chatbot
Custom GPT for yourself, 100%.
SLA would be much slower. It would be like, 24 hours, not 2 minutes and 87.
Purposeful typos to make it seem legit. Awesome.
Well, I mean, that's actually really quick on that. It's really funny because, people ask us like, oh, do people think your doctors are bots? And we're like, no, because our doctors make so many spelling errors and typos that they're like, of course, this is a human being.
Of course. Once the bot figures that out, though, it's over for us.
Yeah,
That's true Turing test stuff,
Exactly.
Yeah. Awesome. Well, Matthew, thanks for coming to join us. Appreciate it.